primary care is an innovative, alternative path to insurance-driven healthcare. Typically, a patient pays their doctor a low monthly membership and, in return, builds a lasting relationship with their doctor and has their doctor available at their fingertips. Welcome to the My DPC Story podcast, where each week you will hear the ever-so-relatable stories shared by physicians who have chosen to practice medicine in their individual communities through the direct primary care model. I'm your host, Marielle Concepcion, family physician, DPC owner, and former fee-for-service doctor. I hope you enjoy today's episode and come away feeling inspired about the future of patient care, direct primary care.
Direct specialty care for me is being able to practice medicine and preventive care in particular in the way that I want to practice it. And so being able to connect with my patients in an in-depth level and really help them get to the root cause of their cardiac risk factors is just incredibly rewarding. I'm Dr. Nicole Harkin of Whole Heart Cardiology, and this is my direct care story.
Dr. Nicole Harkin, MD-FACC, is board certified in internal medicine, cardiology, echocardiography, nuclear cardiology, and clinical lipidology or cholesterol management. After graduating from Boston University School of Medicine magna cum laude, she attended Columbia University for internal medicine residency and New York University for cardiology fellowship. Upon completion of her cardiology fellowship, including serving as a chief fellow, she remained on at NYU as an assistant attending until moving to San Francisco. Passionate about preventing and treating heart disease through healthful, sustainable lifestyle changes, Dr. Harkin works with her patients to create a proactive, personalized cardiac care plan. She is also the Chief Medical Advisor for PlateUp, a health tech startup dedicated to improving health through nutrition, and is a member of Planted Forward, a comprehensive, multi-specialty telemedicine health team. She proudly serves on several committees, including the American Society for Preventive Cardiology Nutrition Working Group and the American College of Cardiology California Chapter Prevention Committee. She currently lives with her family in Tiburon, California, and when not doctoring, she spends the majority of her time with her 3 young children. She also enjoys cooking, yoga, pelotoning, hiking, and traveling. Welcome to the podcast, Dr. Harkin.
Thank you so much for having me. I'm super excited we were able to make this work.
Absolutely. And, we were chatting a little bit about you being a specialist in this movement of direct primary care as a business model. And it is so awesome that even though, yes, you have just gotten started, like I was mentioning, you know so much more than most specialists out there. And so it is such a privilege to have you share your perspectives as a cardiologist and as a specialist on this podcast for other people who are listening in about the direct primary care model and wanting to follow it. So I wanted to start with the fact that you went from Boston to Columbia to NYU, and now you're in San Francisco. So can you please share with the audience about your journey into cardiology and what was life looking like prior to opening your own clinic?
Yeah, absolutely. So I'm actually originally from the West Coast, so I feel like I've kind of come back home in many ways. So yeah, exactly as you said, I was on the East Coast for much of my training. Cardiology was interesting for me. I actually really thought that I was going to do infectious disease, interestingly enough. That was like my thing. I was really interested in international health, did a lot of work abroad, that I was going to get my MPH. And I wish could say there was like some seminal moment that occurred that made me completely shift and change my trajectory. And probably the closest that I can pinpoint it to was actually I was in Africa doing some work in medical school. And I started to really realize that, yes, the burden of HIV and malaria and communicable diseases is profound. Actually, I was shocked by how much chronic disease I was seeing, hypertension, cardiovascular disease complications, congestive heart failure. And then just really at that point started to really completely, internalize that cardiovascular disease is the number one cause of death globally. And so in terms of impact, and obviously I think the heart's super cool and it's interesting too, and the pathophysiology and the physiology, but yeah, just in terms of impact, and if I really was thinking about public health, maybe I should kind of explore this. And then I ended up at Columbia for residency, and cardiology is a very strong program there, and you can't help but like love cardiology when you go there. So that was sort of my path there, and kind of how I landed in cardiology, and just really, it's super interesting. I find it, obviously, as I said, the heart really fascinating, but in terms of what I'm specifically practicing now within the field of cardiology is prevention. And that's always sort of been my jam, and sort of how I ended up back in kind of, I would say, more public healthy type thing, which is, the prevention of cardiovascular disease. So that's been kind of my journey and how I fell into cardiology. And I absolutely, in my practice, love preventing cardiology, treating cardiology, using lots of lifestyle and precision medicine.
Incredible. And, just you sharing that really adds to why you are a preventative cardiologist and a person who specializes in lipidology as well, in terms of being able to give as many details and evidence base to a patient in their personalized health plans, which we'll get to prevent the diseases that we spend so much money and time on, as you well know, and most of us in primary care know, could be avoided. So with that said, how did you go from loving this place of really being able to make an impact preventatively to opening your own direct care clinic? Because it's definitely not a common thing to see a specialist choose a model that is separate from the fee-for-service model.
Yeah, absolutely. So certainly not something I ever envisioned and thought I was going to do, but certainly I would say those of us who, I think most of the DPC docs as well, who are really invested in well care and prevention and spending time with patients, it sort of just naturally ended up evolving. So after finishing my cardiology fellowship, I worked in traditional private practice for a number of years. I had my first child towards the end of fellowship, and then over the course of the next couple of years, had two more children. So was also working in, I would say, a more part-time capacity, although for, a doctor, that's like 40 hours a week, and doing that and just kind of chugging along and doing my thing. And actually it really was and again, very focused on prevention. So I tended to see a lot of patients, lots of the classic cardiology type patients that you would expect, but I also started attracting a lot of people who were really interested in prevention. So people with a very strong family history or lots of risk factors or whatever else, just, being like, is this all there is? What should I be doing? How can I make sure my dad had a heart attack at 50. I'm 45. What should I be doing? And so started kind of building a larger panel of those patients when I was in New York. And as everyone here listening knows, those types of conversations take a lot more time. And it's not as simple as just, handing out a medication, and unfortunately is not super well suited to sort of the traditional insurance-based model where cardiologist is lucky if they get 10 minutes with a patient. So that was sort of what I was doing and just kind of plugging along. And then honestly, it was life circumstances. My husband's job, he got transferred and we moved to the Bay Area, and I had actually just had my third baby. And so she was a couple months old. So took just a deep breath and took a step back, and we were deep in the middle of the pandemic. This is 2020, right? Summer of 2020 when we moved. And so just kind of did a lot of self-reflection. Like, what do I want to join, a Kaiser here or UCSF? Do I want to look for another private practice job? Like, what is it that's going to make me happy? And honestly, it was some of the doctor Facebook groups, and I saw sort of direct care being mentioned. Eventually, sort of there's a California-based one for DPC, and then there started being some specialists talking about direct care, and I was like, wait, this is sounds like a dream. So started learning about it, and that's when I just I'm going to do it. And it's not very like me to just jump for something like this, but decided to go for it. Launched, and I'm sure we'll get into this more, but launched telemedicine at first, and am now in person.
And as you share how, that's not your traditional way of going about life in terms of just jumping into something like leaving fee-for-service and opening your own clinic, given that it was you were being guided by what will work for you and your family and the way you want to be with your patients, When you came from this area where you had a panel of followers who were really, really wanting to do preventative cardiology to San Francisco, where that's not too much of a hard jump to make in terms of wellness is definitely appreciated in the Bay Area, coming into a community that might have been proactive with regards to their health, but in a place where one, medical access is pretty much everywhere, where there is like you said, UCSF, Kaiser, where there is a lot of specialty access. How did you have any hesitancies, and what were they in terms of, how would you build your patient panel, marketing, and how would you start opening your clinic?
Absolutely. So I think one of the biggest hesitancies that I had was just, will this model work, both from a patient acceptance standpoint and then just kind of financially, like, can I make the numbers work in such a high cost of living area? And then exactly as you point out, and I guess this goes along with patient acceptance, certainly the Bay Area is dominated by Kaiser more than anything. And people are, very much in that system. If you're in that system, you're in that system, and that's it. And so people aren't sort of used to sort of stepping outside the box and thinking about, seeking healthcare on their own. It's the type of a commodity that, as again, your listeners are super well aware of, is really different than a lot of other ones. And we're used to just going with our insurance. I think the environment is changing a lot. And I think people are starting to really realize that the quality and the type of care, like if you're well and have no issues, it's maybe not a big deal. But if you really want sort of high touch care where you can get a hold of your doctor, things are different. And so I definitely worried about that. I think thanks to your podcast and lots of other venues, I feel like DPC is starting to be pretty well known at this point. And so I felt like the model for primary care office was pretty well established, but I just didn't know, and still am not 100% confident that it will work for a specialist, because, it is different. It's in some ways a very different model. And again, we'll probably get into that, but I as of now, still have not launched membership. It's still sort of the one-offs and things like that. And so it's a different sort of financial model and offerings and things like that. But I just, again, came back to the fact that I feel like people ultimately, once they realize this is an option, will be willing to pay for better access, better care, and those sorts of things. So definitely had a lot of hesitancies about, if this type of a model would work. And then also moving to a new city and not having a network yet, right? So in New York, I could think of, concierge and some direct care and out of network. That's reasonably well accepted in Manhattan. And I knew a lot of people that were kind of doing it. I didn't know anyone doing it in San Francisco when I moved here. So it was a little intimidating to think about trying to build up a network, a referral network, and then just kind of better understand the lay of the land.
Yeah, I definitely appreciate that, especially because, in a 7 square mile area, there's a lot of people, but at the same time, finding your niche and then having people latch onto that those are challenges that I could easily see in any metropolitan area in addition to San Francisco. So did you strategically plan on opting out before you opened? And how did you start seeing those first patients? Did you see them in your office space, or did you open with a telemedicine practice in addition to an office space?
Yeah. So when I opened, we were still deep in the pandemic. I had a lot of these sorts of question marks in my mind about the model. So what I did decide to do, and frankly, I still had a very, very small baby, and I kind of wanted to just be selfish, and she was my last baby, and spend more time with her. So I didn't want to launch full on into all that is in terms of building the physical space. So I launched telemedicine only. And at first it was a lot of my New York patients, just they found me online. I got, on social and built a website and all these things, and they sort of started to find me. So that was the bulk of kind of the initial parts of my practice, and then started, getting patients off of various other, social media and podcasts and various other ways, and then networking as well. So I sort of hedged my bets a little bit and wanted to kind of start with a very low budget model and see if just what the response would be, and just kind of test the waters and use that time to sort of talk to people and get a better understanding of kind of the lay of the land, as I said. So that was sort of how I started. And then it wasn't actually until this year that I decided to open my doors physically in person.
And when you opened, had you opted out of Medicare to start, or did that come after you had seen some patients in your clinic?
Right. As a cardiologist, I was like, this is going to be a little interesting if I can't see anyone over the age of 65. But again, was not sure what the response would be. So I decided not to opt out to start. I toyed around with the idea of a hybrid approach. But again, because I was telemedicine only and I wasn't sure what was going to happen with the regulations vis-a-vis telemedicine and Medicare, I decided just to kind of hang tight for that first, I would say 6 months to a year. I was still very low volume and just kind of exploring, figuring out what was working, what wasn't. And so I decided not to see anyone that had Medicare, didn't formally opt out, but was collecting email addresses and names and just said, I've got to figure this out. If you're interested in seeing me, I can't see you at this point, but please let me know. So started collecting a list. And I think, people could do it one of two ways. I think, and again, I think if I hadn't been telemedicine only, I would have started sort of hybrid, accepted Medicare patients, billed Medicare, and then opted out once I started to kind of build that list up enough. And then I guess after about a year or so, I decided to just go for it and opt out of Medicare. So I'm opted out of Medicare and that's been great. And, I think the biggest bummer is that I do provide, as I said, I still bill for appointments as opposed to a membership model. And so I do provide super bills. And so for my patients who have PPO, it's nice that they can kind of submit and get something back and things like that. And unfortunately, because of Medicare, it's a bummer they're not able to do that.
Definitely. And, hopefully regulations change in the future in terms of access to healthcare roadblocks. So in terms of when you think about, how you approached your decision to opt out and how in the beginning you weren't opted out and then you decided to, can you give any advice to other specialists who might be in that same position of, do I opt out or do I not? What should they think about if they're considering opting out depending on their specialty?
Yeah, absolutely. I think for what's good to know is that even if you opt out of Medicare, you can still prescribe, you can still order tests, you can still order labs. I don't think I totally realized that at first. So I think that's important for providers to know. And I think that's a good decision tree point. And then I just think also thinking about sort of your mix and it maybe for if you're already established and you're going more in the direct care route. I do know of a lot of specialists that kind of decide to just keep Medicare and then opt out of all of the private payers. So that's a good way to do it. And then just talking to your patients and sort of seeing what the appetite is like and what that looks like. And it may be that once as reimbursements for Medicare continue to drop, it no longer kind of works for you. So that might also be part of the decision. But I think having faith in your model, which is something that I didn't totally have at first, is really important. And so if you really have this confidence, like this is something people are going to want, it's cleaner and simpler just to opt out right away and just be completely direct care. So there's just like no confusions and no, different things to happen depending on the insurance and just being completely insurance agnostic.
When it comes to the way that your model has been set up, you shared earlier how you're not necessarily on a membership basis, but you are on a pay per visit setup. And so in terms of you deciding how you would structure your payment options on your website, you have different blocks that people can schedule an appointment for. How did you determine your pricing? And going into the future, do you foresee a membership helpful for certain types of patients?
Absolutely. So I wanted to start without a membership, and I think that will certainly continue to be a large part of my practice. A lot of my patients do come from internists they're already paying a membership, right? And so I didn't want to have yet another membership that people had to then choose that they have both or what, and it just seems like a little bit duplicative. So, and there's lots of people that'll come to me, just for a second opinion, and they just need to, confirm and have me review everything. And then that's that. So I will always have that. And I think for specialists, it makes sense. You need to have kind of that option. But I am increasingly realizing that the need for a membership, particularly for someone like a cardiologist who does manage chronic diseases and we're doing lifestyle changes. And there's a lot of kind of back and forth over portal messages and a lot of frequent visits and things like that. So I'm actually working with someone right now to kind of set up the structure of how that membership would look like for people who do want to engage with me and have more follow-up appointments and things like that. So I imagine that in my membership, it will be unlimited visits, unlimited communications, et cetera, for people who just want that even more close follow-up and tighter level of care.
Gotcha. And just getting into the logistics of your practice quick, you have chosen Charm for your EMR. And so in terms of this potential of having memberships in the future, did you choose your EMR based on having that potential, or do you see yourself switching EMRs because of certain needs that you might have going into the future because of memberships?
Great question. No, I was not that savvy to think about that far in advance. I wanted something, I actually was really attracted to Charm because of its buildability. And so I really like the idea that, particularly as someone who was just starting out and sort of dipping their toes, wasn't totally confident in my model, you can just build to what you want, right? So it's literally free in its base version, which is what I started at. And then you can add the things that you need. So I slowly added, e-prescriptions when I decided iPrescribe was too much of a pain in the booty to go on a separate thing. So, you just kind of, as you get busier, you can build and things in there. So I really actually liked that. I also liked that it was very automated. So I really didn't want to have anyone else in the practice at first. And so you can set up all the reminders, you can set up the questionnaire. So basically how my workflow goes is someone can book the telemedicine appointment on the website directly themselves. So you can do a web embedded calendar. Once they book it, my EMR will directly send them a welcome link to the patient portal. They'll also automatically get all of the documents they need to sign and fill out. They can upload everything there that they need. And then there's patient reminders. And, a lot of it was really tech friendly. And I know a lot of them have that, but this one, I trialed a couple out and it just worked with my brain as well, which I think is important. And you can build templates, you can do dot phrases. I mean, just stuff that I kind of wanted. And it doesn't have a lot of the stuff that I didn't need. You don't have to have any checkboxes if you don't want them. So I liked that. And then, I just liked the buildability of it. So I did reach out to them through Charm. You can bill someone monthly. So I will start probably with that. I know Hint is very popular at DPC, so we may switch over to that depending on what it all looks like. So I'm still figuring that part of it out.
Now, getting into the personalization that you bring to your patients, I just love that it's so clear on your website, everywhere you look, even your logo, that you are about prevention. You mention that you bring comprehensive personal family history discussions to your patient visits. And then you talk to your patients about dietary risk factors, lifestyle modifications, things like that. Can you give us an idea as to what it looks like when a patient says, Dr. Harkin, I'd love for you to be my cardiologist, even if it's for a second opinion? How does that look like at their first visit?
Yeah, they'll get my intake questionnaire. It has all the standard stuff, but I do also ask sort of early things about lifestyle. So I like to have kind of a jumping off point so that I know kind of where they're at, so we can kind of frame that conversation. So I do ask about nutrition, movement, stress, sleep, and I have some rating scales about behavior change. One of the first questions I ask is, what are your goals and what do you want to get out of this? And why do you want me to be your doctor? So that I kind of know how they're approaching this and what's important to them. So those are the things that I know going into the appointment. I also, as I said, have them upload anything that they've had done before. So if it's a second opinion, for instance, obviously all the relevant testing, I like to see all of that. If they've had any heart testing or recent labs, all those things. So I ideally have all of that in hand going into the appointment. And then the appointment itself is, really going into depth into all of these things. So I like to understand if they have hypertension, when was it first diagnosed? What medicines have they tried, in what order, and how did it respond? Family history and all of those things, and sort of identify. So if this is someone for cardiovascular prevention, what are the main risk factors? Lots of questions about secondary causes. Is there asking all the questions about obstructive sleep apnea. Is there any excessive tiredness and morning headaches and snoring and yada, yada, yada. So there's a lot of that. In terms of the lifestyle questions, for instance, in terms of nutrition, a lot of things I like to go into. I'll do sort of like a 24-hour recall. I usually do kind of a typical breakfast, lunch, dinner. I ask how often they have red meat, how often they have processed red meat. I ask about kind of typical snacks, if they snack and when. I ask about desserts. I ask about beverages, obviously alcohol and things like that. So during the visit, as we're going through these things, I, make comments about different things and different tweaks throughout the way. So I'll usually make some suggestions. Typically, I'll either start with kind of the low-hanging fruit, like the easy stuff to switch, and or the stuff that they feel like is doable, that's going to move the needle the most. And then we kind of have them be very much engaged in that decision about, after I've done some patient education about, we want to try to overall reduce your saturated fat, because I see that there's certainly a significant amount of saturated fat in your diet, and this is where it comes from. And, they kind of already have a sense. And then we talk about, okay, which ones feel doable? And is it the charcuterie that you're having 5 times a night or whatever? Let's decrease it to 2 times a week or whatever, and then I literally type out that's my goal. And then they get a list. And I try to start with like 2 or 3 changes at a time, so as not to overwhelm them. We talk about kind of a testing plan if there is further things that we want to get to better fine tune and better understand their risk. And then afterwards, I send them a summary of what we discussed. And I do have different handouts that I give them to kind of refer to some of the education that I provided during the visit as well. And then they're always welcome to message me between visits on the portal to kind of let me know how things are going, or if they're experiencing roadblocks, and we try to troubleshoot there.
And in regards to the time that it takes for you to review their intake forms, their cardiac studies or labs that they might have uploaded, doing the patient visit, and then creating the summary, about how much time do you dedicate for the administrative part versus the inpatient person part, whether that be via telemedicine or in physical person?
Yeah. So the patient face-to-face visit, they're booked for about an hour. And I try to give myself a little 15-minute block afterwards. Documentation, whether direct care or not, is always, I find, the most challenging part, especially since I send them summaries afterwards. But honestly, those are invaluable. They love them because, as everybody knows, you walk out and you're like, wait, what did I just get told? And so it's really good to have that in writing so they can see it. So, and that's exactly as I've explored this, I think definitely not accounted for the administrative time enough, particularly when I first set my prices. And so that's definitely something I'm reviewing now currently as I go into the new year, about how to reset those prices so that they reflect not just that hour, but all of the administrative time before, all of the administrative time after, and then all the portal messages that I get in between. Because again, as someone who's just charging kind of that one-time visit, I need to be able to charge enough that I'm capturing all that other time. Even though I'm very much a lifestyle first when possible, I have lots of patients on my panel who have established cardiovascular disease, and we use a complementary approach. So I do prescribe a lot of PCSK9 inhibitors, all of those kinds of things, which, as you all probably know, require a lot of paperwork to get the prior auths and doing them every year and yada, yada, yada. So there's a lot of that time as well that I haven't fully adequately captured. So I'm looking, as I look into 2023, that's definitely on the agenda.
And I love that flexibility, with you realizing as you've gone into, more months and your first year of this practice, figuring out what are you bringing to the table in terms of your time and how to have your numbers reflect that. I think that's so important. And it's a perfect time of the year to do that with the new year starting. It's a great excuse to say, hey, new year, new pricing.
Right.
So
right. Right. Yeah. Well, and honestly, your patients will tell you too. I mean, after like probably the 10th patient, it was like, by the way, you should either start charging me for these portal messages or you need to raise your price. Like, I was like, okay, like literally 1 million patients have now been like, charge me for the portal visit, charge me for this. I'm like, okay, like they are, I especially have I have a handful of lawyers and they're like, this is absurd. You're giving away your time. This is not okay. So yeah, once your patients start telling you, it's time.
Awesome. Now, in terms of the testing that you are talking about, once you determine like, great, you've had the workup up to this point and, additional tests like a calcium score or different blood tests could be helpful. How do you talk to your patients about, hey, okay, so I get that you're already paying me cash. You may or may not have a direct care physician, in addition to me. Here are the options for what is standard of care, and this is what is and what is not typically covered by insurance. How do you approach that conversation with them?
Great question. Because as much as we all want to be out of network and not deal with insurance companies, they are in our lives. So with lab testing. So I have contracts with both Quest and with LabCorp. And so I do give them the option, which one, is your insurance typically like, most people know. And then I send them, and so they get the testing through their insurance, and then insurance covers what they want to cover and don't cover what they don't want to cover. But patients unfortunately are used to that, right? So they don't ever really get surprised by lab bills because they've been getting them for decades now, right? So I think people have a pretty good sense of that. If they have a DPC doctor, obviously that is preferable. And then we just run it through there. See, if they have Kaiser too. I mean, so I have a lot of patients who I was very surprised who found me and they have Kaiser, and they're like, I will keep my Kaiser for whatever. But I want to be able to like call my doctor. And so I will often, they'll have a provider at Kaiser that I can kind of give them a wish list. And a lot of them are pretty accommodating, and they'll order testing. I try to be thoughtful about the fact that, let's try to, not everything under the sun. And so we try to get just creative that way and try to make sure that we stick within boundaries. And, I stick with evidence-based testing in terms of the testing that I do. And most of my patients, I will get some sort of advanced lipid testing at some point. And so either I look at ApoB or LDL particle, lots of evidence to show that correlates with cardiovascular risk much better than just LDL cholesterol, particularly if there's any signs of insulin resistance. So that's a big one that I get. It also captures that Lp(a), which I follow the European lipid guidelines. That should be checked in everyone at some point in their life. We don't have medications now, but it does change your LDL goal, and we will have medications in the future. So that's captured within that panel, an HSCRP, those sorts of things. And then I like to look at fasting insulin, glucose, those sorts of things. And a lot of that tends to be pretty standard and covered by insurance. So that's how I handle that part. In terms of testing, because of how our insurance is set up, if you have symptoms, you can get testing. So I can order, if someone has symptoms, that again runs through their insurance, they can get echoes and stress tests and whatever testing they need. When you look at prevention testing, unfortunately, a coronary artery calcium score is never covered by insurance, really. Luckily, around the nation, the coronary artery calcium scores are really fairly affordable. So most places it's $100, some places it's $80, some places it can get up to around $200. But that's typically with, most people that are finding our services, that's within, that's feasible for them at some point. So if that's indicated, and we talk about that and review that test. And then I tend to use a lot of the freestanding radiology centers because those tend to be much more reasonable and also more pleasant. And you're not at a hospital for like 3 hours. So I do those. And then when I need things that do require more advanced testing, then we do that, whether it's, a catheterization, or I'm increasingly actually using CTAs in some of my younger patients with strong family history for prevention. And again, those, if they have symptoms, go through their insurance.
And previously you mentioned that you have been able to create super bills and use Reimbursify with your patients. Have you had much success with your patients using Reimbursify?
Great question. I'm not sure why, but they don't tend to use Reimbursify as much. I have it on my website. It goes out in a message with the super bill. They tend to just file it on their own. I'm not sure if they've started getting very comfortable with it or what have you, but most of my patients with PPO, I think, are pretty comfortable with just kind of getting that filed on their own.
Gotcha. And then with you focusing and having the time, which I love because, it's like going back to what you can achieve in a 10-minute visit is very different than what you're doing now. I want to just highlight again how you are so educated in regards to your board certifications in internal medicine, cardiology, echocardiography, nuclear cardiology, and clinical lipidology. When it comes to being board certified in lifestyle medicine, where do you feel that is important? And do you plan to be board certified in the future in regards to lifestyle medicine specifically?
That is a great question. And one I mean, I think as doctors, we're like addicted to education and things like that. I decided 5 was enough for now because as is, I just started my internal medicine lifestyle knowledge pathway. Oh my gosh. So it's even though I do a lot of CME on my own, I think to keep up the boards, is definitely a lot. So I will always keep a lot of my core ones. And then I think as things evolve, I have explored both obesity medicine boards as well as lifestyle boards. Those are kind of the 2 that are on my wish list. I will say that I feel like you can also, as a physician, take advantage of the conferences and the material and the education and not necessarily get the board certification and feel really competent in those areas. So that's sort of where I've been. I go to some of the different meetings and do a lot of they have tons of virtual CME type content as well that you can purchase. So that's sort of where I've landed on those just because I kind of capped myself off.
I love that. Given that we're recording, during December, it's like you could put, board certification on your secret Santa list. I haven't seen that yet. So you might surprise someone by doing that. So no, let me ask you about, because you have this autonomy to choose what happens in your clinic. When it comes to the tech that you have, we talked about the EMR, but in terms of equipment that you have now that you have a physical space, how did you choose your equipment? Because you are taking advantage of standalone, radiology centers. Did you have a big investment in the overhead when it comes to equipment in your office?
So great question and very timely one. So as of now, I have stuck with just EKG and blood pressure monitor. I am looking at different refurbished ultrasound machines right now. Those guys are expensive. So we're going to look refurbished, and there's some great options out there. So that'll be the big investment either this month or next month. I want to be able to do echoes and carotid IMTs. So that's coming up. And then the next stage is going to be sort of figuring out some additional staffing. So I have a virtual administrative assistant who I love, and she helps me make sure that all the things are happening, documents get back to referrers that need to get to and all that stuff. So that's been instrumental. I probably hired her not soon enough. So that would be my other tip. Don't wait till you're like, I can't do this anymore. Do it sooner. So that's been great. I still want to stay very micro practice-y. I love that model, but that is some of that stuff I don't need to be doing. And so she's doing that now, which is great. And then right now I'm toying with the idea, and I've been trying to figure out if I can get a per diem echo tech. So that will, once I purchase the machine, although I can and have done many, many echoes in my life, I prefer not to be doing them all. It's a decently long test. So that's going to be the next stage of the practice. And then eventually I do want to be able to do stress testing as well. So the next big purchase will be the stress equipment.
And when you talk about this, I hope that you can find an echo tech maybe like in training in school, because, the city is chock full of people getting their education. But when you decided to open, because you're on Sacramento Street, how did you determine which space you were going to have for your clinic? And did you get your space with the intention of having a place for stress tests, a place for echoes, et cetera?
Yeah. So space is a really great question, and one that I stressed a lot about. So initially, when I decided to open up a physical space, I was looking high and low for a sublease. Like I really thought, I only want to be in person a couple days a week. Why don't I just try to find a sublease? And had one that ended up falling through because she decided to kind of close things down. So it was a process. So I would say if a sublease is an option, that's a great way to start for a lot of people, and what a lot of people do. It didn't end up sort of working out. So I was able to find a space that I could sign just a 1-year lease on, just so that if my needs again continue to evolve, and I chose sort of an in-between size space. So I have a waiting room and then 2 offices. So I have my own personal office where I do the kind of the initial consultation part, and then an exam / where my echo machine will go. So, and if that room is big enough that I wanted to get a treadmill in there, I could. So it's big enough that it can work for some period of time, but not so big that the overhead was like crazy, which in San Francisco was a serious concern.
Absolutely. Oh my goodness. It's crazy how, especially during the pandemic, real estate went insane in this whole state, but especially the city. So when we talk about how you moved from New York to California, you're also licensed in Florida. So how did you decide to become licensed in Florida in addition to New York and California? And are you looking to expand your licenses to other states as well?
So great question. As I have done more and more things on social, I do get a lot of requests for other states. At this point, I'm not looking to expand unless it makes a lot of sense for the practice, simply because I'm really kind of focusing on, as strange as this may seem, sort of my local footprint and really expanding here. So that's sort of where the focus is. Although at some point I may continue to get additional licenses. A preventive cardiologist is difficult to find, unfortunately, particularly one who's really focused on lifestyle and plant forward nutrition. So I get a lot of requests from kind of all over. So that may happen at some point in time. But yeah, I mostly want to focus on kind of making a name for myself here. And honestly, I did not realize how much I missed being in person and seeing people in person. I have this great relationship with so many patients, and it's so strange to me that I've never actually met any of them in person or many of them in person. So I'd like to kind of really focus on that. Florida was an easy one because they have a telemedicine only license. So they basically, if you're licensed in any other state, they'll recognize that license. You just have to apply for, I think it's like a permit is what they call it basically. And you have to pay, I think it's like $20 a year to have some sort of address in Florida. So it's pretty straightforward. And a fair amount of my patients in New York spend time in Florida as well. So it definitely made sense.
It's very different than the $800+ that we have for our medical licenses, and it just went up this year in California. So that's so different to have $20 as a permit charge. So even though you talk about focusing on your footprint locally, you're definitely making a huge impact nationally. On your website, you have, multiple resources that you've been quoted in or featured in. And I love that because by doing that, you help bring awareness to the fact that other cardiologists and other specialists can do direct care and the importance of having a physician who knows you. So with that, you've been able to collaborate with different people, different companies. One of the collaborations you have is with Planted Forward, working with Dr. Melissa Mandala, who's been featured on the podcast before, as well as Plate Up. So can you talk about your collaborations that you are so excited about and how you decide which collaborations you'll take on?
It's a great question. I don't do a very good job at saying no. So that's probably that part. No, I think exactly as you said, sort of the more awareness we can bring to sort of a different way of practicing medicine and that you don't have to be miserable with your current medical care. I mean, you probably hear this too. Like so many people get on the phone with you for like the meet and greet and they're like, I just hate my doctor. I hate not the person, but just the system or whatever it is, people are really sick of it. So I think just, bringing awareness to the fact that there's other ways or modalities that you can get medicine. And for so long, a lot of the out of network providers were not necessarily evidence-based providers. And so I think at first you sort of get lumped into this group of, other types of providers. And I think it's, and at least from the view of the lens of the traditional medical providers, they think anyone that's charging cash, they must be like whack jobs, right? And so I think now we're finally starting to bring up, this is probably not at all PC to be saying, but it's totally the truth. People are like, wait, you charge cash? Like you must be like, whatever, prescribing ground up pig hormones or something. So I think people are starting to realize that there are like great, good doctors that just want to practice medicine in the way that they want to practice it, that are providing medicine in a different way. And so you don't have to be stuck in like that model. So both from a patient's and a provider standpoint, like there's other docs you can refer to, So I think educating people about that, also educating people about lifestyle medicine and about plants in general are very health promoting, and how we can change the way we eat and move and sleep is really impactful in terms of our health. And so a lot of the collaborations that I've chosen to focus on really do sort of emphasize that. And, it's not enough to just tell people that, but kind of giving people the tools to do those things. And so with Plate Up, actually, that's one of the companies that I am a chief medical officer for. And that's been really, really fun. It's an app actually that I think a lot lot of DPCs might really find helpful with their patients. So it's a free app that you can download that allows patients to not only track kind of what they're eating. So it's just, they take simple pictures of what they're eating to kind of log their food, and they can also meal plan, and there's a social aspect where they can explore different meals and things like that. And then my favorite part about it that we're really building out right now and focusing on is the interaction and the collaboration that you can have with your care provider. So you can connect with your doctor or RD or health coach on there as well. So they can sort of see at a glance kind of what you're eating on a day-to-day basis and kind of help you make recommendations and changes there.
So awesome. And, as we see how society is really craving quality over quantity when it comes to healthcare, it's such a perfect fit that you are doing preventative cardiology and making an impact again nationally. So thank you so much, Dr. Harkin, for joining us today.
Thank you so much for having me here. This was really fun.
Next week, look forward to hearing from Dr. Amber Beckenhauer of the Healthy Human DPC in Blair and Ashland, Nebraska, and yours truly, as we have a candid conversation about life, DPC, and what's been going on over the past year at Big Trees MD. If you've enjoyed the podcast, tell someone about it. There are still lots of physicians who have not yet heard about DPC, and you can help change that. It also helps others to find the podcast if you leave a 5-star review on Apple Podcasts and on Spotify now as well, and follow us on social media. Help support the work the podcast is doing and celebrate the end of Season 2 by snagging some DPC swag like t-shirts, mugs, and more by visiting the DPC swag shop today at mydpcstory.com. If you're wanting to continue learning more about DPC in the meantime, check out dpcnews.com. Until next week, this is Marielle Concepcion.